I am Roland Andersson, Professor of Surgery at Lund University, which is situated in the very south of Sweden. And I've been dealing with pancreatic cancer some 40 years now. Doing surgery, it's a major surgery we're talking about, and also doing clinical and translational experiments and research on these patients. It's been quite rewarding. What is not rewarding is that the results are marginally better over time. And the reason for that is that patients come too late. So the initial symptoms are very vague. So when they come, they have usually an advanced disease, not a candidate for surgical resection. So only some 15% of those. And even if we do operate, we give them maybe 1-2 years more. So they die in recurrence of the disease. So one way to improve results is to get the diagnosis earlier. To develop a pancreatic cancer is a long issue, usually. It's 10 years or more. But when it starts to happen, it goes up exponentially. So the last year, it goes from not visible, more or less, on an MRI, to maybe being too advanced on lymph nodes and local spread. So there are risk groups, like new onset diabetes mellitus, at the age of 50 or more, and also familial and hereditary risk factors. And the latter is the focus on the SHIELD project. SHIELD addresses familial and hereditary, which is a fantastic task. Those represent some 10% out of all pancreatic cancer cases. But they are usually identified and they are under surveillance because of the risk factor. But these intervals are yearly. And when things start to happen, 1 year is a very long time. So ideally, we should have a simple blood test taken 2 or 3 times a year, because the blood sample will show that there is something going on 6 to 9 months before you can actually see it on MRI or CT scan. And that gives you, with more proper tools, the possibility, maybe not of cure, but of a longer life. And presently, the survival, we talk about 5-year survival, is less than 5% of those with pancreatic cancer. Finding an early, small, we talk about tumor stages 1 and 2, you can improve that to over 40, maybe 50%. It's quite a dramatic increase there. And all of this interest over these 40 years has been through academic research. Out of that sometimes comes something which could make a clinical difference if it reached the population. And that process is through a startup company. So I started Reckon Limited 2015, and it's been a crooked road, of course, but I'm now chairman of that. Small companies have their struggles with financing, but when the SHIELD project came in, it is like a glove, hand in a glove. So it fits in very, very well there. One way to improve results is an early diagnosis, which is not addressed by the SHIELD mission, is that we are completely lacking precision medicine. There's no personalized yet. It will come. Targets and treatment that has given any benefit for the patients. That will come. So that will also be addressed. So if you combine then early diagnosis through, for example, the SHIELD mission and that project with better therapy, we might end up in a much better world and outcome for these patients. I mean, to take something historical, I'm that old, but when I studied medicine, the mortality in breast cancer was 50%. Now it's more than 90% that survive. And you wish a similar development and journey for patients with pancreatic cancer, which is a dreadful, it's not a nice death. They're really suffering. Fatigue, extreme weight loss, and a low quality of life. Concerning improvements in general for the total population of pancreatic cancer, we talked about early diagnosis. We talked about directed therapy, more in precision, depending on what that particular patient needs. We are on other things there, within RECCAN and outside RECCAN, academically and hopefully through also startup companies. But surgery, for example, has come to the very end. It's done now minimally invasive, mortality is less than 1%, and there's not so much else to do because you have to remove it. As of today, there's no other destructive therapy like cooking it down, boiling it down. Radiation is not working to the extent that you would like. So with new combinations, together with the early diagnosis, it's hopefully a much brighter future. The risk patients that are addressed in the SHIELD mission project are hereditary and familial, and there's a great variation in their risk to develop a pancreatic cancer. From slightly increased when you have some family members, the more family members, the higher the risk, of course. Then to those with some mutation, that actually is associated with a 10–20% risk of developing pancreatic cancer. And they live under that threat, and they've seen relatives die in this. So they are highly motivated to participate, and they always ask, what's coming? Well, when will there be a good test that actually finds the tumor before it's visible? We're now into the first year of SHIELD, and I think recruitment of first patients is actually ongoing now. There's a lot of startup problems to fix before things are running. There's another 3 years, and by then we have hopefully found all the patients that we assume to find, and that we have a surveillance program that will continue. So there should be a life after SHIELD, including surveillance also. We have probably more knowledge about the genetic situation and how many patients that actually are developing a pancreatic cancer and the risk, because mutations, they start sometime and then they are inherited. So that's one thing. So hope is to have something that is sustainable and continuous, but also to write guidelines. Because guidelines, this is a small proportion of patients. Pancreatic cancer is quite a rare disease, but it's turning the second or third cause of death in cancer. So something that would be beneficial would be a surveillance system that persists, and guidelines that are based on best possible evidence, and hopefully the SHIELD project will contribute with new information and new results and data that are going to be fundamental for an improved guideline, European guideline.